Hey, everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. I wanted to talk a little bit about that, right? Is the direct laryngoscope, the direct view laryngoscope, or DL as we've been calling it, right? As it's often referred to, is DL dead?
No.
And I think we're all in agreement here. It's the hard no, right? Do you have a tool for most of the time that is, you know?
I'm a Mac 4.
Quick. Yeah, we're talking about video.
Oh.
Do you have a tool that is, quicker and faster? And yeah, you can use that most of the time. That doesn't mean you get to throw away your you get to throw away your standard laryngoscope. There's times, whether that's you didn't charge the, somebody didn't charge the head on the video laryngoscope. It was working just fine, and then sunspot, and then all of a sudden it's not.
Well, you're only as good as your view too. If you get something blood something covering your view, you're condensation, which air track's kind of nice. The new blades heat when you turn them on the tip, but that's not going to work every time.
Perfect. Yeah, nothing's perfect in that space, right? But yeah, I think that was really we shouldn't stop training with our.
It is still a good backup.
Yeah, and there's cases where it may just need to be the first
GI
go.
bleeds,
Yep.
hematemesis. You're not going to get a good look. You're just going to you're going to get blood on it, and then once you get blood on it, you're done. So you just do direct.
Do deal. Yep. So yeah, don't stop practicing with.
They haven't built windshield
tool.
wipers onto it yet.
Not yet.
And we've talked about in the previous episodes, right? Is when you are practicing, try practicing with different blades.
Absolutely.
That's about the time when one of the LEDs doesn't work, or your partner comes back from the truck with one thing, be like, here's a Mac 3.
And know the differences.
Or a Miller 3.
If you're using Miller, know what anatomy you're moving out of the way. If you're using a Mac, know it's going to the vallecula, and just understand that there are differences in the tools. Now, I can still move anatomy out of the way with the Mac if it's big enough and I'm able. It's not cheating.
Okay, I'll bite. Yeah, right. Yeah, so you're clearly baiting, right? And
No, not at all.
What, of course, his reference is that, the textbook way, right? The classical teaching is that with a Mac blade, we're going to put this in the vallecula, and then we're going to lift up and basically cantilever the epiglottis up. The epiglottis up. Whereas a Miller blade, you're just going to directly move the epiglottis out of the way. And there are fundamentalists that just think that is it, right? You can also grab the epiglottis and move it out of the way with this. Frankly, it's Scott's my personally preferred method. I've heard people teach just like try the vallecula first, and if you don't get a good view,
well, try what works for you first.
Back it up and then hook the and get a good look. It's just I would prefer to do the thing that I know is going to give you a view.
That's designed so that way. If you put that in the vallecula and you have it deep enough by putting pressure downwards, or forwards on your view, it's gonna flop.
Roll it up.
That's gonna flop up. So sometimes it might be you're not deep enough, and that's gonna give you the better view.
So I almost always, when I use this, I go too deep, come back out, and let it slide till I see it flop over, and then at that point you're right where you need to be. Also, if you see this while you're intubating, you're doing something wrong.
Sure.
It's probably your positioning. You probably didn't ramp, but this should not be happening. And I don't like this either. But
I don't like that. I don't like that particular handle either. But
I know Scott does, or not Scott. Ray, I think you were a fan of this one, aren't you?
We have a curved one, so we actually use this. Either one's fine with me, but a lot of times I find I hold it completely different sometimes than other people.
You hold it right-handed.
I hold it almost down at the. I hold almost down here.
Yeah, that's
I'm more of a
similar,
it's it's down here. In all honesty, is where my hand is. I'm not doing this. I don't think I've ever really done that, but it's like what you talked about, what works for you. and I hold an air track pretty similar back and forth.
Well,
you don't need that.
air track's designed to be 3 fingers and a thumb. If
Correct.
you're gripping it, you're going to pop the top off, and you're going to
Yes,
lose
you
that
can't.
camera view. And
you should not be struggling. A lot of these things are not forceful, and I think
No.
that's what people confuse it with. To your point,
Show
is
your
everybody
sizing.
everybody thinks you need to manhandle it, and you don't.
no.
That's when you cause damage, actually.
You know, the reason those devices that you talked about, the air track being basically for the 3 finger, that is how a anesthesiologist would traditionally hold this, is,
Correct.
you know, just with a couple
Like that.
fingers. And, you know, I find if there's anything that gets tired when I'm intubating, it's my thumb. It's my thumb, because it's back here. It's back here. The only other thing I wanted to say about DL is that we often line it up with the axis, and we try to. So first of all, I would hope anybody watching this is aware that this channel is not a place to try to dump the tube, right? But if you're a student or you're watching this for the first time, this is your view channel, and you don't stick things.
Don't obstruct your view.
You
Correct.
don't. Yeah, you don't put anything in this channel to obstruct your view. So you're actually going to introduce that tube from another position. In my case, I like to bring it completely in, just essentially 90 degrees from the side. We'll talk about different ways to orient the tube, and I'm a traditional hockey stick guy, so I would bend it much like that, and then get my view and introduce this again. He's got a different way, and we'll talk about it. But when I rotate this in, now this is pointed exactly where I want it to go. A couple other things that I just wanted to point out is we forget about. Our wrist is a gimbal, right? Although we're taught to do everything midline, once you get your view midline, you can rotate your hand up and out, right, and make more space, right?
Well, and when you're introducing that, you want to start on the patient's right side of their mouth and sweep the tongue
Correct.
Yep.
to the left and out of your way. It's not just a straight in.
That is, yeah. There's a 3 or 4 little nuanced things in there, right? Is getting in there, displacing the tongue, getting your view. You can rotate your wrist out, make some space, right? Optimize that view, and then deliver your tube. The other thing that we need to talk about is you just don't bury that. You just don't bury that in the patient's airway, right? This is the concept of progressive laryngoscopy, where we're going to advance little by little, right? And then, what am I viewing? Okay, no, that's still all tongue. Okay, I'm starting to, appreciate airway structures, top of the epiglottis. I'm going to advance a little more. Our students were, even though I taught them exactly that way, right? You watch them struggle. You're struggling. All right, back up and let's slow down. Go bit by bit and tell me what you're seeing, right? And then boop, 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 boop. Oh, there it is. And then, they can drop it in.
But you definitely know your anatomy, know what you're looking
Absolutely.
at, because things change. And, if you get in there and you see something that doesn't look right, it's probably not right, whether that be a traumatic or just the way that they were built. You just know that, know your anatomy, know what you're looking at. Like Scott and I have done just for fun before, is taking pictures and put them upside down, and it's a gooey looking airway. Okay, what are you looking at? It's like, I know this. And it's like, you got to think through it, and you're like, oh, this is upside down. Okay. And then it's like, yeah, just know what you're looking at. Know where the tongue is. If you're looking for the tongue underneath of you, something's wrong.
Yeah, I think, too, you have to know your equipment. So you have to practice, and that's hands-on training with a mannequin. And you need to innovate. I think one of the things that we tried to push in hands-on training, too, at UH is innovate in realistic environments. So a lot of times when you go to do training, it's like, oh, they're on this nice table. We're in a very well-lit room. I'm going to bend over and just do this. All I have to do is kind of lean down. And it's like, no, in our world, a lot of times it's not perfect. It's the ditch, the side of the road, the floor most of the time. So move the patient to the floor then. Innovate how you would on the floor. If this is what we're going to do, then you should practice that way, and you have to practice with your equipment. And not all equipment is created equal, even for DL. Everybody's stuff's a little different. We use the Innobright brand that we're showing right now in our department. We're very happy with it. everybody just has different stuff, so you have to know how to use it.
You're right. There's a lot of difference. There's a blade out there that's just plastic, and it actually gives a little bit when you're moving if you do, and so there are differences. The bulbs reflect very well off the cords because they're phosphorus, right? Mm-hmm. So that makes a big difference. So you should have them illuminated really well. You should see pretty white cords in there. This is not the time to say, okay, I need a 7/0 tube. You should have already had that ready.
Loaded up.
Yep.
Just another point about the tools, right? There's different types of handles and blades, right? So this is more of a traditional, yes, there is a special bulb in here, right? Or a series of bulbs in the older ones. But that does fit on a standard, this is a fancy laryngoscope handle base, but it's a standard base. There are also fiber optic ones that have the bulb in the handle, and the blade is nothing except a conductive channel, fiber optic conductive channel down to here. Those are not interchangeable, right? So if you're working at multiple agencies, if you're purchasing stuff, you really got to make sure you're matching up the equipment with what your capabilities are, right? That's just 2 weeks ago. I was on an ambulance, and there was a fiber optic base and standard blades, and somebody was going to have a really, really bad day when they went to go use that. It's like, guys, these things, they don't work together, right? So pay attention to that, especially if, again, you got random equipment or stuff donated or whatever. Pay attention before you put it in service, right?
And remember, the teeth are not pivot points.
No kidding.
Yeah,
is that bad?
It's bad.
That's frowned, huh?
That is frowned.
That goes back to knowing your equipment, right?
Yeah.
Yep.
Knowing how to use the equipment, knowing that the Mac blade, that if you're not getting it, you may not be deep enough. You may not be in the right spot, and that's why you're struggling. Or the Miller blade's not long enough. It's not the right size either. I've had issues where I've had to change my blade size because I guessed wrong doing my initial assessment, or I've had to struggle a lot to get, because I was too stubborn to give up and say I need a different size blade.
That's a great point. I don't care if you're the best intubator in the world, it might not be your day. And if you're in there and you're spending a lot of time and not just another second, just another second, just another second, that adds up, and your oxygen reserve is gone. When
and
I teach
ideally,
the RSI,
having someone call out what your pulse ox is doing.
I love that. And when I teach the RSI, I go a little further and I tell them, if you're doing this, hold your breath until you get that tube. And if you're feeling like you need to get a breath, they've already needed it. So back out and know when to relax and take another shot at it. Get the oxygen back up.
That's a mental thing for providers. You gotta be ready to accept input from others. That when you're trying to do direct laryngoscopy,
Anything.
If you're trying to deliver an endotracheal tube, right, and things aren't going to plan, you're absolutely right. That's like, one more second, and it adds up. It adds up really, really quick.
And if somebody says, "Hey, no, that's time,"
who in this room's been in an airway too long, right? I think everybody at some point, right?
Even the basics listening. This is your job.
Yeah,
to say,
absolutely.
Stop.
Smack us on the back of the head. Don't literally smack us on the back of the head.
90, 88, 85.
Yeah, heart rate's increasing.
Yeah,
blood.
Yeah, absolutely. And
I got question marks for blood pressure.
Remember, good basics are the ones that are sitting there and saying, "Hey, idiot, stop looking at the monitor. Look at your patient. They're doing something." Maybe they can't fix it, but they can tell us something's wrong. They can read capnograph, like we said. They can read pulse oximetry.